Dr. Rajendra Prasad sir needs no introduction. He has 6 innovations credited to his name, and he is better known as Terminator. So he will be giving a talk on the sewing needle microcapsulotomy to avert Argentinian flag sign. Welcome, sir. Please come on the dash, sir.
Okay, good morning, friends, ladies and gentlemen. And thank you, Dr. Arvind, for keeping me in this beautiful session on innovations. And Dr. Arvind has always been very kind to us and nice to all of us. Yeah, yeah, one of the very active person and one of the very, very vibrant ophthalmologists. Like he's always into innovations and a very good clinicians also. So the topic which I'm going to talk about is the saving needle microcapsulotomy. Friends, you know that we come across all these different kind of intumescent pearly white cataracts. You may come across with the intumescent soft immature white cataract, which has a hyperhydrated fluffy cortex. We come across with intumescent mature white cataract, where you have a swollen and flocculent cortex with voluminous soft nucleus. And the third type is the intumescent hypermature white cataract with a partial cortical liquefaction. And then we come across with intumescent extremely hypermature white cataract with the total cortical liquefaction. So these can be categorized with the help of the OCT images, and OCT images help us in differentiating the type of the intumescent white cataract. But all of them have a very common character. They all have a very thin and fragile capsular bag, and they have a very high interlenticular pressure. So what happens the moment you puncture the anterior capsule with any device, whether with the needle or with the forceps, you would get a volcanic eruption of the fluid out of the capsular bag. And now this eruption is primarily because of the high interlenticular pressure with the fluid which is there inside. This fluid comes out with a high pressure. And what happens many times when you're puncturing the anterior capsule with the device, and you could see this kind of presentation, like the moment you puncture the anterior capsule, because of the pressure, the tear which we created on the anterior capsule would extend to the periphery radially and results into this kind of total division of the anterior capsule into two. And this is has been described as an Argentinian flag sign by Perone in 2000 year. Now he said that this is primarily because of the raised interlenticular pressure, and the raised interlenticular pressure could be because of the posterior to anterior compartment pressure. And he has given a beautiful theory for this. And this used to be one of the very common complications in intumescent white cataracts. And the incidence has been put forward almost 3.85% to 28.3% of the cases may come into this category. So because of the complexity of this situation, the various techniques have been described. So you see that many innovations have taken place to deal with this complex situation. And the quite important, like very commonly practiced technique is called as the small needle aspiration technique, where we just use a needle to puncture the anterior capsule and aspirate the fluid from the capsular bag to decompensate the pressure in the capsular bag. But what we have seen, like even while using the needle, the moment you puncture the anterior capsule, the tear starts extending to the periphery. Now this is something like unusual, like because you're trying to decompensate the pressure in the intraventricular cavity, but then you get a extension of the capsular tear to the periphery. So we had a presupposition that it's not only the interlenticular pressure which is important in the extension of the capsular tear. There has to be some other factor there's some other reason also involved in the extension of the capsular tear. So we described this phenomena with the saving needle microcapsulotomy to avert Argentinian flag sign. This is our publication. And we found that it's not only the interlenticular pressure, it is the configuration of the tear which we make on the anterior capsule. Now the configuration could be different, variety of the configuration we make. Like if you're using the needle, you make a linear cut on the anterior capsule. If you use a Rexis forceps, you may create a square kind of cut on the anterior capsule, or many times you make a tear with the capsule or Rexis forceps. And what we have seen is like if you are using the Rexis forceps or the needle, so what kind of cut you make on the anterior capsule before you start the capsular access. So this is a linear cut. That is what we make on the anterior capsule. And even if you're using the Rexis forceps, we first tear the capsule. We make the cut in the center and then start tearing the capsule. So these two actually things what we commonly do. So this is how you use the Rexis forceps, tear, and then start the capsular access. So what happens when you make a tear on the anterior capsule or cut on the anterior capsule because of the raised interlenticular pressure, there would be a very high propensity of this tear opening up and extending to the periphery. So this is natural. Like if you make a cut, the cut will open up very easily. And this linear cut, the moment you cut the anterior capsule, the linear cut starts extending to the periphery. This is what happens, the formation of the Argentinian plaque sign in these cases. This is how it happens. And so we had a hypothesis, like if instead of making a cut on the anterior capsule of this kind, why not to make a hole on the anterior capsule, hole of this kind. So if you are able to make a hole will have a much better control on the extension of the tear, because it would have a more resistance against any kind of forces which is there inside the capsular bag. So what we did, we just devised a device. So this is called as the saving needle microcapsulotomy. And you can see the tip of this device is round and pointed, unlike the tip of the needle, which is a sharp and cut. So if you puncture the anterior capsule with this device, you'll make a hole on the anterior capsule. And if you puncture with this device, this is the needle, you make a cut. So there is a difference, because if you make a cut or you make a hole on the anterior capsule. So if you make a hole will have a much more resistance on the anterior capsule. So this is how we use the device until you stain the anterior capsule, and then just put it vertically on the surface of the anterior capsule and make a hole. Now, once you make a hole, so any kind of pressure which is there in the interlenticular space would come out through this hole, and because it has a greater resistance, this pressure won't make any change in the hole and won't extend to the periphery. What happened? It's almost over, but I'll just go to the last slide, I think. So we can make a single hole or the multiple hole on the anterior capsule, but the multiple hole has to be within the 5 millimeter zone. And this is the last video how it should be done. Like you need to inflate the anterior chamber with good amount of the viscoelastic. Take this device and go through the main or side pot, and you just have to keep it vertically straight on the anterior capsule and give a nick on the anterior capsule. So you get a hole formation, and then you can start the capsular access from this hole. So to conclude, this is the simplest form of the device, but very highly effective. and adequate back decompensation. You know that before you start the capsular access would prevent the Argentinian flag sign. And this has done in almost 100% of the cases. Thank you very much.
Excellent innovation, sir. So, are you doing any clinical trial to compare it with the other techniques like the Zepto or the flax assisted capsular access?
The clinical trial, Dr. Arvind is doing now. So he'll be doing. So I haven't done, I've just innovated this technique very recently, so we'll be doing. But I think Dr. Arvind is the best person to do the clinical trial on this.
I have a question.
Yeah.
In fact, what is the size of that puncture on the amputated?
Size of the puncture. See, size of the puncture would be a needle tip. It is going to be a micro, and if you, because the needle tip has to be very sharp, so it will make hardly 15 to 20 microns of the puncture on the anterior capsule. It's not big.
And how does the cataract meet?
How does the?
Cataract meet? Right, cataract. How does it come out? Do we aspirate through the puncture?
No, no. So as I said, as I told in the fluid, the pressure, actually what happens, because there are 4 types of the intumescent white cataract. The intumescent cataract, where you have a total liquefaction. If it is a bulky material, it won't help in that situation. It's only the last 3 types of the intumescent white cataract, where you have a total liquefaction, partial liquefaction, or the fluid which is there at the center. Many times you have multiple pockets. So that is the reason you have to do multiple puncture. So it's basically you have to puncture, because you know that if it is a full of fluid, just puncture, the fluid will start coming out of that hole. You don't have to do anything. You can just milk it out. Sometimes you use a cannula and you milk it out the fluid out of this hole from the center. But as you have seen, generally what happens the moment you puncture, the fluid start coming out. Now, actually, it's not only the fluid, it's the pressure. Many times gas is there inside. It's a pressure gas. The gas comes out. And even if the fluid doesn't come out, you don't see any fluid coming out, still the capsular surface or the intralenticular space decompresses, even if the fluid doesn't come out. This is what we have observed in many of these cases. Thank you.
So what a wonderful innovation. Is it available commercially, sir?
Yeah, it's available. It's last year this device was the maximum sold device
Wonderful.
by the Epsilon.
Congratulations.
Epsilon is marketing it. Yeah. Thank you.